case study on the next generation. So this is the case. Can you make a diagnosis from this question? You should be able to. What is the problem? A 32-year-old, age is always important. Male present to the outpatient clinic due to what? Dance-like is a buzzword. Movement. I'm dancing. I have a slurred speech and a violent outburst for no reason. These 2-3 words plus the age should trigger something in your ears telling you that this may be something you should be worried about. And when you know that this is what you worry about, keep on reading and trying to find anything that supports your diagnosis and stick with it. And when you get the diagnosis, every question they give you, use it to answer it. That will make your 6 case studies easy and the computer has to shut off. It can't take you anymore. You report significant decline in what is IQ test compared to when he was 20 years old. There's a problem. Significant decline in his IQ test. This is a problem, right? 32-year-old. You feel depressed most of the day due to this uncontrolled dance-like movement. All this is supporting your diagnosis. Father told him that he had similar symptoms when he was 30 years old. I tell you, this is a genetic problem. Client is the only child. So they only have one child, the mother. And so he does not know whether he's being passed on to the next generation. But this is key, right? Then when you're doing case studies, pay attention to these words. When you see no, don't just skip it. No bladder issue, no bowel issue. That tells you you can rule out any other problems that may look like this, but it does not look like that. No weaknesses at the end of the day. There's a reason why I put that there. When you examine the client, slow eye movement, right? And he has uncoordinated hand movement. There's no ptosis, right? And his vitals were normal. Have you figured out what is wrong with this patient? You have all the buzzwords. That's the way NCLEX will present it to you. They will make it shorter. They will make it longer. If you look at the Q bank, sometimes it's long and it's frustrating. I just condense them and give you all the buzzwords that you need. 32-year-old, I'm dancing when I move. I have a slurred speech, violent outburst for no reason. My cognitive function is declining compared to when I was 20 years or 12 years ago. I should be more inclined, my cognitive function should be going up rather than declining, right? His father has similar symptoms. He's depressed. He has no bladder, bowel issue, no weakness at the end of the day. His eyes, he has some vision problem because of slow movement and he's uncoordinated. His vitals is normal. Do you know what is wrong with this client? Can you guess? You should be able to guess. This is a buzzword case for you. I give it to you. Let's do some content. This problem is hereditary, right? It is autosomal inheritance. That means if this is the mother plus the father, okay, and the mother is the one that is diseased, or if the father is the diseased, so this is what you have. So the mother, you have to cross. So if the mother is diseased, is autosomal dominant, I'm taking the big one, one of the gene is affected, okay? And the normal gene has to be the small a, times if the father is normal, it's going to be AA. And you get 1A here. This 1A cross with the one big A, the mother is normal, so this had to be small a. So this cross with that, and you get A, big A, and small a, and two small a's. If you disease, you just have to have one big A, and this is the disease patient. So 50% of the children is going to be affected for every autosomal disease, 50%. That's the problem. Half of the kids are going to be affected. That is autosomal dominant. Because of that, we call it, this disease is 100% penetrance. Are you getting an idea? It's hereditary, it's autosomal. One person has to be affected, whether the mother or the father, depending on. So this one, we assume that the father is normal and the mother is the one that has the disease. So small a is normal and big A is abnormal. 100% penetrance. That means from each generation has to have this disease. Each generation must have the disease. You still can figure it out based on the case. If not, I can tell you it's a progressive degenerative, okay, neuropathology. That means it's a neurological problem that is progressive throughout. So those are the keys I want you to pay attention to. What do they have? Dance-like movement. You saw some slur speech, some depression. You find it in the father. Those are the clues I give you. And what is the problem? What do you think this patient have? He has Huntington disease. So that's your diagnosis, Huntington disease. So this patient has Huntington's disease. This is a problem that you should be able to be comfortable and to be able to, when I give you a case, you'll be able to go through easily. What is Huntington disease? This is not multiple sclerosis. It was not any other disease. We'll go back to the case, but this is classic Huntington disease. Chloroform movement, slur speech, depression in the family, dance-like movement. It's like a snake, right? That's what it shows. What is the problem with Huntington's disease? If this is your brain, okay, if this is your brain, okay, and this is the brainstem, this is the brainstem, and this is this cerebellum. There's something here like that. This is in the center called the basal ganglion. It communicates with the cerebrum. Basically, that's the main function, and that control your motor function. His job is for motor control. And how does he do that? Okay, it's very important you understand the pathophysiology about why these people do that. This is you. When you want to move, so movement is stored in the brain. We call it the motor cortex of the cerebrum. That's where you move. This is how you move when you want to move. So you don't have to, when you learn how to move, everything is stored there. You can get out of bed and just walk around and do your thing without not thinking, because you recall those information in this portion of the brain, the cerebrum, right? But the basal ganglion is very important. It's an inhibitory portion. So these provide inhibitory action on your movement. So when you are at rest, what it does to you is it tells you don't move. So it blocks the brain from the cortex. It tells the cortex, hey, I don't want you to move. So the cortex, this area, it tells them not to move because so this they go back and forth. So this is inhibitory and this is an activation. So when you want to move, you tell the basal ganglia, I want to move, and then you start moving. So the inhibitory effect goes down. And if they ask you, what is the neurotransmitter? The neurotransmitter for inhibitory function, you all know it's mostly GABA, right? That's the neurotransmitter we have, GABA aminobutyric acid. So this basal ganglion send the information to the cerebellum and said, hey, I don't want you to move. You're sitting down, so don't do dance-like movement. So you don't move. When you want to move, the cerebellum tell the basal ganglion, hey, I want to move. So this GABA inhibitory effect goes down, and that's how you move, so that you don't just move around if you don't want to move. So there is a negative or inhibitory pathway from the basal ganglion and a activative pathway from the cerebellum. So that's how you move. You move back and forth. What happened? In Huntington disease or in normal people, we have this something we call glutamate. We have genes, okay? So we have genes. If this is the gene, there is a place in the gene that code for CAG. This is a neurotransmitter. You code for this, and this lead to what? Glutamate. Of course, in Huntington disease gene, they have a bunch of it. They have multiple repeats. Usually we have like between 20 to 30 of the CAG. But people with Huntington disease, they have greater than 40. And this lead to formation of glutamine that go and deposits here. It destroys the basal ganglion. So you have your basal ganglion destroyed. This is the pathophysiology. Basal ganglion destroyed by multiple repeat because of the gene. The CAG gene is destroying the basal ganglion. That's all. You don't have to know any other, can't teach you any other very confusing stuff. It's all neuro. But this is all you need to know. The basal ganglion is destroyed because you inherit some mutated gene that causes destruction of the basal ganglion. And I told you the problem, right? What does the basal ganglion do? It provides inhibitory effect. So it provides inhibitory effect on the motor cortex. If there is no inhibitory effect, well, you just move uncontrollably. So there's no control with your movement. So that's why they go into coriform movement, because they go like snake, dance like. It's like they having tick. This is another word they can use, tick-like movement. And this is the problem. There's no control of the cerebellum. So your motor function is keep on moving. Motor portion of the brain will just keep on move and move and move and move. And you have a problem. And that is their problem. It's a very, very bad disease. Onset is when you are 30 to 50 years old. So the patient you saw, it was 32. So early onset. If you are the repeat, that means mutation, CAG, is a lot, like in hundreds. Look, high, normal, yeah, onset will be earlier. So you can have a kid who is like 10 years old, he has Huntington because he has too much repeats. and that destroys the basal ganglia so quickly, and they get into trouble. So that is the main function of that. What do you think? If you can't control your body movement, you can't do anything. You go like a snake. What is going to happen? The rest of your muscles that are very important get into trouble. And that's where I want you guys to think. When you're doing these cases, think about, you don't have to memorize symptoms. So the muscles, other muscles that you have to control, get into trouble. Your speech muscles are in trouble. That's why you get like slur speech. Your eye movement, you can control it. So they have eye movement issue, right? The basal ganglia control your cognitive aspect of it too. So they have decline in their cognitive function. And your emotions, sometimes the basal ganglia has a portion of it, even though sometimes the parietal lobe play a role, the basal ganglia can play a role. So emotional outburst. And this is where they have depression and some psychotic problem. Do you have to memorize this? You don't have to. You just put it together. You see, this is their problem. Right. And of course, the coriform movement. Do you think you can control things to when you have this coriform movement? It's a problem. It's the chorea that kills them really badly. They don't like it. How would you be able to diagnose this thing? It's not easy to diagnose. Okay, so diagnosis, it's not easy. So family history, if it's in your family and you have symptoms, yeah, then we can figure out it. Sometimes they can confirm it. Confirmation is by genetics. That's how you can confirm it. You can do imaging of your brain. So EEG and an MRI can give you some function of the brain and see what is going on. Huntington disease. Let's go back to the case again and see if you get a picture now. This is the case. 32-year-old present to the outpatient clinic due to a dance-like movement. Dance. He's dancing. He's 32. There's a reason why I give you age. He has a slurred speech. Right. And violent outburst. Neuropsychotic problem. He report decline in his cognitive function compared to when he was 20 years old. He's depressed because of this dance-like movement. His father has the same symptoms when he too was young, but he has no what? Bladder problem. That's the key. It's a neurodegenerative disease, but it's not a demyelination problem. That's why it's no multiple sclerosis. It can be no bowel problem. He has no weakness at the end of the day. It's not myasthenia gravis. Okay. He has slow eye movement. Fine, you think it's multiple sclerosis, but no, he has uncoordinated hand movement and no pitosis. All this thing is for you to focus to be able to rule out other symptoms. This is the way they will present Huntington disease for you. And you have to know the underlying problem and be able to manage it. So like we said, it's a genetic problem. It's progressive. Cognitive function is affected. They have neuropsych problem. Okay, depression, hallucination, psychotic issue, right? They have speech issue, okay? Speech problem. They're going to have some swallowing issue also. They have this coriform movement. And so there's coordination, going to have some language problems. All these things you have to think about it so that you can manage them. What do you want to do for this patient? I'm not done. Even though with they have uncontrolled movement, sometimes when they want to control themselves, control movement, if they give it to you, most people think it's just control movement. If they want to do uncontrolled movement, if they want to do control movement, look for dystonia. So the muscle will have some dystonia effect. So it's also a problem for these patients. These are his problem. You got to fix him. For your test, when you're doing case study, when you're studying, don't memorize them. Look at it. If I have this, what are the things would I do for this patient as a nurse? Look at it. Cognitive dysfunction, neuropsych issue, speech problem, swallowing, coriform movement, language issue, and dystonia. How will you fix this patient? If you're taking care of this patient, what do you do? And which people will you call? Which interdisciplinary team will you call to help you fix this problem? You can't do this alone. So what do you think? Who are you going to call and then and figure out what is needed? Who are you going to call? Who are you going to call to help you? Tell me, who do you need? At least you need an occupational therapist, right? So this guy need interdisciplinary team to help with that, right? You need a speech evaluation, language and speech evaluation to help with this patient. You may need some nutritionist because he can eat properly because of the speech and language problem and the swallowing is going to be a problem. So they're going to, physical therapy will help with them in movement and coordination, but mostly occupational therapy is the one that will play a role. So physical therapist. All these things, people is going to help you to deal with them. They're going to have a balance problem. That's occupational and physical therapy will provide that. They will have gait issue. So those are all going to be something that you have to pay attention. And if they give you a case study, you got to think about all these things, how you're going to manage this patient. They're not going to have bladder problem or anything like that, but this is their main problem. Okay? There is no cure for this. No cure. We don't have the magic bullet, but we can treat their symptoms. I'm giving you everything you need to know for this disease process. No cure, but you can treat for their symptoms. If they take you to interdisciplinary team, yeah, you should be able to pick up those people to help with this guy problem ongoing. Okay, so there is no cure for it, but we can treat the symptoms. What do you think this patient, how will you treat this patient? Do you know any medication that can treat the particular symptoms this client is having? For sure, the psychotic outbursts, we can give them antipsychotic, you know? So antipsychotic, like antipsychotic. You can also give them antidepressant that may help with their problem. But there's one medication that will decrease the coriform movement, the hyperkinetic movement that you have to know in case they give it to you. That doesn't cure, is FDA approved to help with this coriform movement. Does anybody know it? It's a very good medication. You have to know the function. It depletes, basically, it leads to decreased production of monoamines. So you want to destroy them or inhibit them. Anybody know what medication is used for this? So there's a medication that if they give you this case, they're going to ask you, you have to remember it. Okay. So the name is tetrabenazine. This does not cure the problem. It just decreases the hyperkinetic movement. And that is a drug you have to know. In addition to this, to treat symptoms, but there is no cure for this problem. You have no cure at all. So that's that a condition. So you will be able to know this and to figure out it. If you're taking care of this patient, okay, in a hospital, what is your number one thing, your priority function for this guy? What should be your number one priority function? What will be your priority function for this patient who has all these problems and you're taking care of them? Number one priority for Huntington patient that you're taking care of them. What should be your number one priority? Let me see if somebody got it. I see safety, but it's not, it's not my number one. Safety is good, but what else? This is what kills them. Safety for rigs is the same. This is what killed them. Number one is aspiration. So they die from pulmonary complication. So this is what kills them. So you have to pay attention that pulmonary complication is what kills them. So they get like easy to get what kind of infection? Pneumonia. So they're more likely to get like pneumonia. Is number one, you know. They don't going to get like UTI, like other things like, so mostly pneumonia is what is going to kill them, respiratory failure and all those things. So you tell these people, make sure they get their vaccination, okay? Get their vaccination, routine vaccination as much as possible. You may not know what they will throw at you, but I'm just telling you key facts, buzzwords, what is the most important. You have to know the drug. You have to know what is going to kill them, what interdisciplinary team you got to bring in to take care of this patient, what are their symptoms, be able to recognize the case in the question and be able to figure out. Don't get confused with Alzheimer's disease. They all have neurodegenerative disease. Don't confuse it with Parkinson. I will talk about resting tremor, okay? Max-like face. When you're reading the case, you know, you got to think like a, I don't know, they want you to be in the middle of the provider evaluating the patient. And so you'll be able to do your differential diagnosis. Like there's no way you should confuse this with the Parkinson disease. You know, they have resting tremor. These people are dancing, okay? They're moving, but it's not the tremor. It's the, you know, coriform movement. They will use the word, the tick-like movement, you know. They have to give you the buzzword, okay? They have to give it to you. If they don't, then the question is not, they don't dare to treat you, to trick you. They have to give you all those things to be able to rule out from Alzheimer's, Parkinson's disease, any other multiple sclerosis, myasthenia gravis. You got to put it together. Said, this is not it. And when you figure it out every answer choice. Don't think about any of the other differential anymore. You've cleared them off. All you care about is Huntington. So you ask yourself, what do I know about Huntington? When they give you treatment, pick an answer that will treat Huntington's problem. Okay? The problem is they don't live young. Oh, they can live for a long time. If you diagnose it, so they have up to 20 years. 20 years, most people 20, 30 years, and then they will succumb to the disease process. So life expectancy is very lower for these people because of this problem. Okay, it goes down because of this. And they have 20 to 30 years to be done. This is Huntington disease. You should not mix this.